Good afternoon and welcome to today's webinar on why modernizing hemorrhagic stroke workflows can't wait. My name is Dan Actor, and on behalf of RapidAI, we want to thank you for joining us today. It's an honor to have such a distinguished physician, researcher, and leading voice in the neurosciences with us today. Dr. Sabarish Nadarajan is a neurosurgeon and a neurointerventional surgeon at Sharp Healthcare in San Diego, and he is also the president and CEO of the Brain, Spine, and Vascular Neuroscience Institute, also in San Diego. In this webinar, Dr. Nadarajan will explore the main challenges we face today in treating patients with hemorrhagic stroke and why the time is now for modernizing stroke workflows with robust processes, AI, and treatment options. At any time during this presentation, we encourage you to submit your questions in the box on your screen, and we will answer them in the Q&A portion of this webinar. And without further ado, I'll hand it over to Dr. Nadarajan to help us learn about ICH workflows in the era of AI. Thank you, Dr. Nadarajan. Take it away.
Thank you, Dan. Thank you for the introduction. As all of you have heard, I am Dr. Sabarish Nadarajan. I do neurosurgery, which is surgery to the brain and spine open, and neurointerventional surgery, which is catheter-based treatments to the brain and spine. And because of that, I take care of a lot of stroke patients, including ischemic and hemorrhagic stroke. As you would all know, we all think about stroke as, hey, someone has a blockage in an artery and then they are not doing well and they go to a hospital and they can get a medication or they get a revascularization where they open up the vessel. But hemorrhagic stroke is a special kind of strokes where there is bleeding in the brain, and the bleeding in the brain can be either in the substance of the brain or in the spaces inside or outside the brain. So that's really what we're going to talk about, which is the hemorrhagic stroke. And I've been doing neurosurgery for almost 20 years now. I started learning neurosurgery between University of Washington, Seattle and University of Buffalo Neurosurgery, which is the mecca of neurointerventional surgery. I practiced in Boston and Florida for a little bit. And as introduced before, I currently work in my own private practice, which we call as Brain, Spine, and Vascular Neuroscience Institute, which is BSV Neuroscience, which has a very healthy partnership with Sharp Healthcare, which is a large acute care hospital system with 4 hospitals in the metro of San Diego. And a lot of this experience comes from opportunity to think about many different things. My passions are understanding why patients get brain aneurysms, where we work with fluid dynamics, understanding why patients get hemorrhages, how to do minimally invasive treatments, how to use AI, how to use navigation, how to use robotics and enhance AI to create better minimally invasive solutions where patients can go back home faster the same day or the next day after a procedure, and we can help them with very, very difficult problems in the brain and spine. With that, we'll go into intercerebral hemorrhages. As I said, there are special types of strokes. They constitute 15% of strokes. They are not the majority. They are actually a minority, but they are some of the most severe strokes that you see. They have 30 to 40% mortality. A lot of the patients are dead or disabled if you're not able to act and if you're not able to do something for that in a timely manner. And it's been a neglected part of stroke care where there's not been a lot of studies and there's not been a lot of randomized controlled trials. There's been just a very recent trial published where we know in a small cohort of these patients, if you meet this criteria, then these patients benefit from a surgical evacuation and they actually have less death, decreased stay in ICU, better chance to recovery. So I think we are at the tip of the iceberg with care of intracerebral hemorrhage patients. There's a lot more to come, and there's a lot of people around the world working to improve outcomes in these patients. And with that, I think there is more increased focus from a lot of the bodies to care for intracerebral hemorrhage patients. So when we talk about intracerebral hemorrhages, today we're going to talk about 4 different cohorts. We're going to talk about management of these patients and why time is critical. We're going to talk about when to transfer, when not to transfer, We're going to talk about how to select these patients for all these treatment options and how AI and technology is going to catapult all these things into a better workflow so that we don't have these limitations that we have in care of these patients. Um, this is very recent, as you can see, in 2026 from Mayo Clinic. They have this thing called as a code ICH. A code, all of you have heard about a STEMI code, which is a code for the heart. You have stroke code, which is an ischemic stroke code. But there is a big effort nationally and with a lot of bodies and a lot of people interested in stroke to create this thing called as a code ICH. And what that is to create an ultra early alert for care of these patients, which will be bundled into metrics of analyzing the quality of how a stroke center performs in this country. And American Heart Association has been very, very interested in this, and slowly they started putting targets for stroke centers around this country, not just for ischemic stroke, but for hemorrhagic stroke care. And that is coming down the pipeline, and that will be very important in future certifications by Joint Commission and American Heart Association of the stroke centers in the country. And what it is really, just like in ischemic stroke, we have, hey, patient comes into the ischemic stroke into your stroke center, you need to have an imaging at a timeline, you need to have medical therapy at a timeline, you need to have surgical intervention at a timeline. And you can see those are the timelines that the code ICH is necessitating, which is imaging within 25 to 30 minutes, blood pressure control within 30 minutes, reversal of anticoagulation within 45 to 60 minutes, and a neurosurgery assessment within 15 minutes of an intracerebral hemorrhage detection. Uh, the AHA quality guidelines are a little bit lax, but they kind of ballpark around the same time. A little bit to talk about, what we do with Sharp Healthcare in San Diego. You can see the map on the right side of my screen, where you can see downward in the orange is Mexico. We are right on the border. And you can see we have divided San Diego into all those colors. And Coronado is a hospital out in the Coronado Island, which covers the areas in the brown. The areas in the green is covered by our comprehensive stroke center, which is Sharp Grossmont Hospital. It is the second busiest ED in the state of California, because if you go east of that area, there's nothing till you hit Phoenix. And then you have the downtown area, which is covered by the Metro Hospital, which is Sharp Memorial Hospital. And we have relationships and partnerships with Tri-City Medical Center, which takes us north into Oceanside and covers Escondido and sometimes even into the Temecula Valley. With that, we have currently one comprehensive stroke center, two thrombectomy capable. We are thinking of elevating all of it to, how do we plan care for such a big community in our system to get this. And I think intracerebral hemorrhage, we just started creating our own pathway for code ICH, which I will show very soon in our slides. So we all know time is brain, and we all that then came from, I would say, from ischemic stroke care, where every minute so many cells are dying. It's the same thing with hemorrhagic stroke. Every hour that passes by, your chances of having a favorable outcome in these patients decreases by 5%. So why not act in the same way or think in the same way when someone has an intracerebral hemorrhage, just as we do in an ischemic stroke? And you can see here, I kind of put these two together, where on the top you have ischemic stroke, on the bottom you have intracerebral hemorrhages. So the patient arrives, same thing. A doctor arrives in the same timeline. The stroke team arrives in the same timeline. The imaging is done in the same timeline. Medication on the ischemic side is TPA, versus on the hemorrhagic side, it is anticoagulation reversal and initiation of systolic blood pressure control. It is initiated at the same time as a pharmacological management. If you can do that in ischemic stroke, you can do that in hemorrhagic stroke too. And then surgical solutions. You want to put an external ventricular drain. You want to put in a burr hole for evacuation. You want to do minimally invasive surgery for evacuation of hematoma. You need to do a decompressive hemicraniectomy. Can all that be timed just like you have thrombectomy, which is a neurointerventional surgery that we do for ischemic stroke? So why not have parallel pathways? Why is there a disconnect? And we looked at it in our system. You can clearly see that we are not meeting those timelines in intracerebral hemorrhage care, but we are meeting these timelines in ischemic care, and those charts need to be level. And that's why we started working on this very, very, very intensely. This is this is what we have in our system as kind of preliminary targets for what we should do if a patient with intracerebral hemorrhage comes in. And you can see if the patient comes in at 0 minutes, within 10 minutes, we want to have a stroke neurology consult to a neurosurgery consult, really, to say, hey, there's a patient with intracerebral hemorrhage, possible intracerebral hemorrhage. And then we need to have the CT head done within 20 minutes. And when the CT head is done within 20 minutes, the ED physician activates the code ICH. And we'll talk about how that works, especially with our current AI-enabled systems. And then we are targeting to give antihypertensive therapy at 30 minutes, a neurosurgery consult at 40 minutes, reverse the anticoagulation at 60 minutes. And you can see we start the antihypertensive at 30 minutes, but we want to get control of the blood pressure by 60 minutes. And then we move on to, we still haven't decided about the surgical intervention and how we're going to plan it. Again, this is very preliminary, and we're trying to set these standards and see whether we can fit into this criteria of how to do these things and these timelines. And when we think about stroke care and ICH care, we always think about swim lanes because there are so many different parties involved. And I'll talk a little later of how AI integrates all of this. You have ED physicians who are seeing the patient when the patient comes in. They get a CT scan. The CT comes back either from AI or radiology, and then they call a consult. They call a neurosurgeon to come a consult. They clarify what are the blood pressure parameters. Do we need to reverse the anticoagulation? A lot of this comes from neurosurgery. And there's a stroke RN, and the stroke RN immediately starts taking control of the blood pressure. We're going to be treated in protocols in the pharmacy where if someone says blood pressure less than 140, we have order sets which go on. We have, someone comes in with Coumadin, someone comes in with Eliquis, we have the correct reversal agent go on, and all these sets will be put in so that the stroke RN can throw it in. The pharmacist is very involved in this process because they have to make sure the drugs are prepared. Where do these patients come in? Are we going to give it in the CT scanner? Are we going to give it in the ED? Is the patient going into the ICU? What are we going to do? So the pharmacy departments of the ED, in the radiology department, and in our ICU work together to figure out how do we administer this in the timely fashion. Okay. And they're calling our neuroscience ICU to see how these patients can get in there. And then the neurosurgery team is also looking at this. A lot of the time we use AI. We already have what hemorrhage we have in our phones. And we are talking to the relevant people sometimes on the chat messages on the phones, as I will show it to you. And then the neurologist is involved because if there is no surgical intervention, then the neurology team does hyperosmotic therapy to decrease the swelling around these hemorrhages and to give seizure medications if needed. So you can see that we create these swim lanes where every person knows what their role is and who is in charge of the patient, who is the treatment decision maker of these patients as these patients come down this pathway. So we kind of going into how this happens in these 4 boundaries that we talked about. So how are we going to give this time critical patient management, given that we know all the certifying bodies are going to tell you this is the way you need to meet these timelines, including Joint Commission and American Heart Association, where they're going to tell you need to be able to provide intracerebral hemorrhage care in this timely manner with these timely deadlines, right? So what is happening? If you really think about it, patient came to the ED, patient got a CT scan by the ED provider, then there's a radiologist who looked at the CT scan, they found a hemorrhage, and then what did they? They again call back the ED, they tell the ED that, hey, we have a hemorrhage. Now the ED doc seeing three, five, four patients, how many ever patients they are seeing, they have to label their patient and they have to figure out, they need to call the neurosurgeon, they need to find who is the neurosurgeon on call, and they need to page the neurosurgeon. And they page the neurosurgeon calls them back, right? And then we figure out, well, this patient can be in the hub, this patient can be in a spoke hospital, in a peripheral hospital, and does this patient need a transfer? All of this takes time. All of this takes multiple phone calls, and there's a huge role for error, and there's a huge space for not managing this patient in a timely manner. And I don't think this is something that we can do in 2026 and have efficient, fast, precise care for your patients at a multidisciplinary level. So what do we do? We go from that to here. What do? We have all our patients on this app called as Rapid, where when a hemorrhage is every patient that has CT scans in our system, they're all pushed into a cloud, and the software, the AI-enabled software, is able to detect that there is a hyperdensity. Of course, it's a hyperdensity screen, so it cannot say, is this a hemorrhage versus is it a bullet in the head, or is it a tip of a catheter in the head? But it can say that it's a hyperdensity, and majority of the times, a hyperdensity is a hemorrhage. So that lets an alert that quickly comes to the phones of the neurosurgeon, to the ED doc, to the stroke RN, to the radiologist. Everyone knows that there's an ICH, and you can look at these images on my phone. I know that there is an ICH in the ED as a neurosurgeon before someone calls me, because already my app has told me this is what it is, and I already looked at the patient and I'm prepared for the call. Sometimes I call the ED and say, "Hey, you haven't called me yet. There's this hemorrhage. What's going on? What's the story?" Or there's a chat where I chat with my stroke RNs who are in it. "Hey, no one has called me about this. What's happening with this patient? Where is this patient?" So you're able to get to the specialist very, very quick the moment you know there is a hemorrhage in the scan, which I think is very useful, and it connects a lot of people, and it enables us to provide precise specialist level care to the patient right at the entry when the patient comes in the ED. This is, if you can see, we have a chat in the app, and this is a real-time thing, and you can see that at 5:14 p.m. the Rapid detected that there is a hemorrhage. So at 5:11 p.m. the patient walked in, and then we are going from bottom up, from the left side, and then 5:14 it detected a hemorrhage. 5:16 it says it's a hyperdensity. And then you can see that the rapid response team is ordering the blood pressure to be controlled. There's a radiologist who's chatting, says that what is the volume of the hemorrhage, and then the volume of the hemorrhage can be calculated today by AI, and I'll show you how precisely it can calculate in the coming slides. And then you can see that a CTA is done, and the radiologist is already chatting that there is no contrast extravasation. So this is a very, very good tool where you can see everyone is in it. And if I join this chat, say at 5:38, I can go back and look at what happened from 5:14. So I know what is happening to this patient, and every person can be part of this team of taking care of this patient without leaving their homes, without leaving their offices, when someone who is critical in your ED needs to be taken care of by multiple different specialists. Um, this is a demonstration of, it's a video demonstration, and you can see here, this is how exactly it happens on our phone. You had a code IC, you saw that there's a hemorrhage. Now I can scroll through this, and you can see on the left frontal region, there's a hemorrhage. And there's a little bit of a subdural too, and it says, what is your midline shift? And it can quantify the midline shift so that if you have a second scan, you know what it is. And here you can see it says this is the area you have the hemorrhage, right? And when I scroll through this, you can see, I want to show you this thing, which is, you can see it fuses two different CT scans. CT scans done before and CT scans done after, and it can say, hey, you know what? This red area is the area that there is more bleeding, or this bleeding has expanded. And it can even fuse and say, hey, your midline shifted. So it's like a weather map, if you think about it, where you can see your weather moving. Then you can go into different kind of, sagittal, coronal, axial reconstructions, where you can look at the scan in detail. As a neurosurgeon, for me, this is where planning for my surgery starts. If I'm going to do anything surgical for these patients, and I can invite a consult. Let us say let us say I want to call the neurologist, and I can talk to him, and I can actually share my screen and talk to him, and have a video consult with him if I have a question. And let's say I have a scan, I have something I need to show in the scan, and say, hey, I need to talk to you about this. I can show it from my screen, and he will be able to know on the other side, oh, this is what I'm talking about. So this enables very fast, very quick, patient-specific communication between multiple different specialists. And as doctors who work in this thing, we are all busy. We are always doing something, and then in between our day, there is a patient who needs an urgent care, an urgent decision making, and you can also say, hey, I need to go for the procedure. This patient needs to go to the OR, and we can select that right there. So this is how I think 2026 and further care needs to be provided for these patients, rather than an archaic method of, hey, I get a scan, it goes to the radiologist calls someone, we're going to activate that risk code. I really think this saves time, this connects people, this bypasses steps and multiple phone calls, and enables better specialist level care to the patient immediately. Right. And you can see here, it can very accurately calculate volume down to an accuracy of a cc. And the other thing is, a lot of the times we talk about this, especially when we have repeat scans, these scans are done at different gantry angles. And then there's someone debating, oh, I don't think this hemorrhage is larger. I think this hemorrhage is, oh, I think there's more hydrocephalus, there's less hydrocephalus. All this objectivity is gone. And now you have a software that puts everything on the same gantry angle, superimposes it, and tells you it is bigger, it is not bigger. And you don't need to have any subjectivity or three people opining on whether this is bigger or smaller, especially when someone is having an acute catastrophic event like an intracerebral hemorrhage. Right? And what does this do? It makes you hit your timelines. Right? In hemorrhagic stroke, it has been proven that if someone is on anticoagulation, their chances that their hematoma or the hemorrhage is going to become bigger in the next hour is 25%. So if you don't reverse that anticoagulation within 60 minutes, this patient is going to have a bigger bleed in 1 in 4 patients that hit your ED. And what does that mean? Mortality and morbidity. But if you can reverse your anticoagulation within 60 minutes, you have reduced your mortality and morbidity, which translates into decreased length of hospital stay and better discharge outcomes. It's the same thing with management of blood pressure. If you can control your blood pressure, you reduce hematoma expansion, and hematoma expansion, reduction in hematoma expansion translates into better functional outcomes and reduced mortality. We're going to switch gears and talk about what does it mean using AI and the app to do transfers. We have so many hospitals. Some people have primary stroke centers, thrombectomy capes stroke centers, comprehensive stroke centers. Some centers have neuro ICU. Some centers have neurosurgeon who doesn't go to the hospital. There is no neurosurgery performed in the hospital. So how do we create and work among a network of hospitals? And how do we care for all patients who come into intracerebral hemorrhage, no matter which ED they show up, right? And these are some general guidelines which have been put out by American Heart Association. And there are some must transfer. That is, hey, someone has intraventricular hemorrhage. Someone has a hemorrhage greater than 15 cc. Someone is having hydrocephalus. Again, when you say must transfer, what you're saying is transfer to a facility that has advanced neurosurgical care, right? So in our hospital system, it is not a big deal because at Sharp Memorial, Sharp Rosemont, and Sharp Chula Vista, we have advanced neurosurgical care. So we really don't do inter-hospital transfers as much, but there are a lot of systems in the country where inter-hospital transfers is a thing. So this is very important for them because now AI can tell you, we have Sharp Coronado Hospital where we don't go into neurosurgery. There, from that hospital, I can know, hey, this morning I was on call. I told them there's a small hemorrhage, keep them there. And but the most important thing is that you should own this network. As a physician, you can't say, hey, I don't think you need neurosurgical care and forget about this patient. But what Rapid does is it keeps you in the loop. It's your patient. It comes in your app. If there's a bigger, you tell them, hey, I need a repeat scan in 6 hours. If the patient has an expansion of the hemorrhage, then you know that this patient will come to you because it's going to pick up on your app that there is hemorrhage. So the criteria is small hemorrhage, deep locations. If the patient is neurologically intact, if there's none of the red flags, or let us say some patient already has a DNR, DNI, I don't want any aggressive surgical intervention, then these patients don't need to be transferred to a bigger center where there is advanced neurosurgical care. And what does this do? You can see here, this is one of our patients who had a very, very small hemorrhage. We told them, hey, keep the patient, where they are. And if this patient has a hematoma expansion, we'll take them into our center. And we're able to look at that 6-hour scan through the Rapid app. And as long as it stays stable, then you're done. And we are able to guide the care in our peripheral hospital there, then transferring from the patient from there to our bigger center. And what does this do? This really, really is very helpful for the patients in the first place. You don't want to be driving 20 miles to a bigger hospital when you can be taken care of in your community. When you transfer a patient from one hospital to the other hospital, the care in the interim, at the time of transfer, is not as good as in either hospital. So patients can deteriorate when they get transferred. So that is a risk. And there's a cost associated with it. Who is paying for the cost? The hospital system is going to pay for the cost. And there is money lost from the hospital that is transferring, because if the patient could have been taken care of that hospital, then that hospital is losing money. And if you're taking in patients into your complex, busy, comprehensive stroke center who don't need to be there, you're clogging the system, you're overburdening the system. You're not able to pick on patients who really need care, and you're caring for people who don't need care, and it decreases the efficiency of your care team. So for all these reasons, it's very important to think about which patient needs to be taken care of where. And I think having AI and having a blanket AI which can come to your phones, irrespective of whether you are in the spoke or the hub, and decide on transfers and who you can take care of it. And I think you need to own the entire system. You need to make protocols, transfer protocols, and have AI deployed on it so that there's no confusion of how you can do this. Uh, uh, and all of this needs to come together. You need to have AI deployed in all your hospitals. You need to be able to communicate on your app. The monitoring scans should be screened, and you need to have ownership of the patient, irrespective of whether the patient is in the hub or in the spoke. If you don't have all of these things, I really think people will be hurt, because you may say, hey, the patient needs to be kept there, but then the repeat scan shows a massive hemorrhage, and you've forgotten about the patient, that patient will be hurt. So it's very important. Everything comes with how you set it up and how you keep your patient safe, with protocols implemented across the system. Um, so how does this enable us to select treatment options and patient selection? Um, Enrich is a trial which I talked about, which was published in 2024. It's a multi-center randomized controlled trial where I think for the first time surgical intervention has has changed the outcomes in intracerebral hemorrhage. And what has it done? You can see the three graphs. It's decreased your length of stay, including your ICU stay. It has decreased the number of days that you need to be on a ventilator, and it has decreased mortality, and a staggering decrease in mortality. So this is the first time, and again, I think this needs to be studied further. There need to be multiple studies that prove this concept, but at least we have light at the end of the tunnel, right? That there's something we can do to these patients that we can make. And again, it's a select cohort of patients with this inclusion criteria. They are aged 18 to 80 years of age. They should have a spontaneous primary ICH, which means that it's not an aneurysmal rupture or an AVM rupture. The volume of the hemorrhage should be 30 to 80. It should be supratentorial because we have separate criteria for infratentorial hemorrhages. And the first time they found out that it matters, time matters. And again, this all ties into what we're talking about, that, if 24 hours they're better, then maybe 12 hours they're even better. Maybe in 6 hours they're even better. It's just that we haven't done the study yet. Right? And GCS 5 to 14, and they should have been people who are walkie-talkies before they had this. So if you fit this criteria, then these patients benefit if you have what we call as a minimally invasive paravascular surgery, which is basically you put a port, like a little bullet, down into the head, directed into the clot, and under microscopic magnification, you can go in and clear these hemorrhages. And that actually improves the outcomes of this patient in terms of decreased ICU length of stay, decreased hospital stay, decreased mortality, and all that transfers into cost savings for the patient and the community and the hospital. Okay, so this is what we think is the future of hemorrhagic care, where you can do precise, specialist-directed treatment for individual patients depending with AI, because AI can clearly say, you can see, hey, the hematoma is gone, and it's showing you what part of the hematoma is gone. This is a patient who had a surgical evacuation, and you can clearly see this tells you, hey, you know what, that part of the hematoma is gone, there's a little bit left. And this is, I think, precision medicine, where you can precisely do what you want to do, and it's timely. You don't have any bottlenecks of people calling each other, a radiologist giving a report. It goes to the surgeon right away, and you're able to provide care and direct care and assess your care in real time as it's happening when these scans are being done. This is a review of 1 year of data at Short Grossman Hospital, which is our comprehensive stroke center. We did 17,000 scans, non-contrast head CT, and you can see that it said in 10% of scans there was a hyperdensity. And then we looked at who are the people who meet the enriched criteria, which is people who have a volume of 30 to 80 cc and age of 18 to 110. And that was 158 scans. And then when we tried to do other exclusion criteria, we dwindled it down to 82 patients. And we found out that there are 10 patients who were candidates for this MIPS procedure, which if we had done, these patients would have gotten better, would have had decreased length of stay and decreased mechanical ventilation days, but we didn't do it, right? So I'm sure if you go back into your systems and you do an analysis like that, there are so many of these patients who have been proven to have a benefit by a randomized controlled trial who are not currently getting their therapy, and their chance of getting out of this faster and recovering to a better extent than what they would be without doing this procedure. So, and as AHA and Joint Commission comes more and more on understanding the metrics around this, they're going to look at this and they're going to say, hey, if you cannot do this, you should not be taking care of these patients, right? And this is a lot of revenue for a hospital system. If you really think about it, every time you have an ICH detected, you actually have a code on your DRG that the hospital systems actually can bill for. It reduces your futile transfers and the cost of the transfer. If you're doing a surgical intervention, you have a higher DRG. And if you're decreasing the number of days the patient is in the ICU, in the ventilator, and the days in the hospital, that's a cost saving, which is a lot of money you save. And the most important thing, you take care of someone and they are better than where they need to be. And it's precise, timely care delivered by a specialist directly. Right? And we all talk about everything we buy in a hospital, we have to do a return on investment. And yes, I showed you how you can save money taking care of people, but the government has approved that you can actually bill for your AI. So every time the AI reads your scan, you can actually reimburse up to varying from $380 to $660, and you can offset a little bit the money you invest in having AI enable a better level of care for your patients. Thank you. You have any questions, please?
Yeah, that's great. Thank you, Dr. Nadarajan. Really, really great content, and your passion for ICH patient care is super evident. And now we'd like to open up for some Q&A. If you have any questions you want to ask of Dr. Nadarajan, please use the chat box on your screen right now. And I'm going to open up the chat box. All right, let's see here. First question, Dr. Nadarajan, if you're thinking about implementing AI, hemorrhagic AI technology, where would you install this across your network? And what do you think is needed for a successful implementation and afterwards adoption of this technology?
I think it's very important to think and define what is your network, right? A lot of the hospitals think that, the hospital you sit in is your network, right? You got to really think about where your patients are coming from, and you got to identify your network. There are certain hospital systems where, the network is all the hospitals that are owned by that hospital system. And sometimes it's not the case. There are other hospitals that are owned by other owners, but they all send patients into your hospital system for care. And if you are someone who is sitting in the Apex Hospital, and in your comprehensive stroke center, you got to take ownership of all these other hospitals. Make sure you write and help them write their systems of care for stroke care. Understand what patient needs to be transferred, when a call needs to happen, and all of that. And over and above that, all these hospitals need to have AI-enabled image detection installed so that there's timely access for these patients who have a problem right to the hub of the hospital. So to answer it, it should be in every single hospital from where your patients come from.
Great. So the converse of that, what are some challenges or some watchouts that you have seen or that you foresee when implementing AI for hemorrhagic stroke?
So I have implemented AI in stroke at many hub centers before in my career, and the biggest things that I see is that, hey, I deployed AI, but then nothing happened, or patient didn't have the care, and the commonest reasons is the hospitals don't talk to each other, right? And the transfer protocols and the protocols are not written. If you are a hub and if you are adopting a spoke, they need to have seen you, show up in person, talk to them. This is the way I set up my shop. I would like you to set up your shop this way so that we can talk to each other. We can work together. We can do very similar care in both places, and we can have a protocol that transfers from there to here, right? And that is very important. Ownership of the process, the system, or even outside the system, the referring hospitals. Unless that happens, if you just deploy AI, the AI can be, finding so many intracerebral hemorrhages for you, but if you don't own it and if you don't take care of it, then it's not going to go anywhere.
Yeah, great, great. Speaking of that, speaking of the process, what is your workflow when you, as a neurosurgeon, get an ICH notification on your phone? For instance, like, do you ever turn your app notifications off? And at what times do you call the team or not call the team? What's your personal workflow when you get a notification at home or in other places?
So it really depends on, in how many days you're on call and how many days you're not on call, and what all different call panels you're on, right? As you know, we've been in San Diego and we're trying to develop this over the last 2, 3 years. And so I currently take a lot more call than what I would do when I'm in an established practice, which I used to be in Boston. I would take less number. So today I take a lot of call. I take 15, 16 days of call. So I don't switch my app off because I don't want to miss anything. It's difficult to switch on and switch off your app every other day. But if you're someone who takes only calls 5 days a week, or 5 days a month, you can actually switch it on and switch it off. But you can also set different tones for different notifications. So if you have an intracerebral hemorrhage, you can show a notification. If you have an LVO, because I take LVO call for thrombectomy, you can have a different kind of a notification. And a lot of the times I have a little blip that comes on my phone that I know that there is a new scan that is done or there is something that is identified. But then every time there is an intracerebral hemorrhage, there is actually a different alarm or a beep that comes on, and I know that there is an intracerebral hemorrhage. The first thing I do when I see there's an intracerebral hemorrhage is because it's on my phone, I take it and I scroll through it. It literally, like this morning, I was working out in the gym. I had an ICH evac and I was on call, right? It literally took me 10 seconds to scroll through the scan. And patient had a very small subdural hematoma. I kept working out, right? If this patient had a huge hemorrhage with the midline shift, I would say, okay, let's find out where this patient is. I would give them a call, right? So you can actually, especially in the busy lives that we live with our personal lives and our professional lives, you can easily in your phone look at and say when you need to, hey, drop whatever you're doing and give a call, or this is something we can take care of. It'll come to your plate at some point.
Great. Yeah, that's a great answer. Um, let's see. Getting back on the question about buy-in at your institution, you mentioned buy-in a couple times, not only at your hospital but across the system. If you had to break it down, what are some things that you did to get buy-in for implementing hemorrhagic AI, or what are some recommendations that you have for viewers and listeners about how to take this initiative and get buy-in from their leadership to implement AI in hemorrhagic stroke?
I think the biggest thing is you have to start small and become bigger, right? If you go into a new hospital system and you say, I want this deployed in every single hospital around me, it may or may not work, right? But if you start from your comprehensive stroke center and you have great times. And when the Joint Commission or AHA comes to certify you, they look at you and say, you know what, you've been amazing. When compared to national standards, then your hospital system is already they know that this is working. So now it's easier to say, you know what, I need it in every hospital in our system, right? And now with that, and then your transfer protocols, and if you create an efficient workflow around it, the hospitals see the value of it because it's going to translate into dollars. And with that, then you can go, you know what, there are this hospital system which is right next to us, but they send us so much hemorrhage patients. Can we go and talk to them and convince them that this is what we do, and can we partner amongst us? So I think it's a stepwise fashion of how I would do it. You got to start at your hub and then slowly percolate outside.
Yeah, Dr. Nadarajan, your comment about starting small, I think, is a perfect dovetail to our last question here. How do you encourage small community hospitals to utilize this type of technology? Some of these smaller hospitals don't have the resources to manage hemorrhagic patients, and they might be too afraid to keep them, and prefer to transfer out as soon as they suspect a bleed or are concerned about longer transfers.
So in the small community hospitals, I think it's even more important because you don't have a neurosurgeon in your door, right? So you're going to have someone come in with a hemorrhage and you're going to sit on it and someone may get hurt. That's number one. Or if someone comes in with a hemorrhage, they're going to say, you know what? This hospital, you cannot take care of it. Every hemorrhage goes to the other hospital. You're losing dollars, right? For both ways, it's not good. The best thing to do is have a tie or a partnership with a bigger hospital system and work with someone who is leading stroke care in that hospital and create protocols and a tie and implement AI so that AI can get these patients still in your door. You can take care of patients in your community, and whoever needs to be selectively sent out from that community to a bigger hospital, you can do that efficiently.
Yeah, that's great. I believe we have one more question. So I'll ask this and then we can close. Would you be able to share your experience and process with our clinicians and our hospital administrators if they wanted to talk to you about your experience?
I would love to. It's every hospital system or community network of stroke in this country its own maze, right? In terms of who are the treatment decision makers, who are the key players, what cost economic barriers or solutions are available to create a network that is efficient for care in that community. And it's important to understand, as you know, I always talk about this in the clinical way. My PAs or my nurses or something like, this is what we do. This is what we have always done. That's not how you can give precise medicine, right? Precision medicine is for that patient, for that problem. If you say this is what we do all the time and this is what we have done all the time, then you are not creating precision medicine. It's the same thing for when you create a network, when you create a business relationship, when you deploy AI. You got to think about what is in the community, what do you have, what are your barriers, and you have to create something. And I would be happy to chat with whoever your team is if you want any help from my end.
Yeah, that's great. I think that's a great one to end on. So for everyone watching and listening, thank you again for joining us today as we explored the question, why modernizing hemorrhagic stroke workflows can't wait. We appreciate your time and your engagement. And if you're interested in learning more about Rapid's hemorrhagic solution or reaching out to Dr. Nadarajan to talk about his implementation personally, please reach out to your local rep or simply fill out the Contact Us page on our website. Thank you, everyone. Good night.
Thank you. Good night.